So, hello students, today you are continuing to study course of Propedeutics of Internal Medicine. My name is Oleg Bychkov. I am Associated Professor of Department of Propedeutics of Internal Medicine number 2. And today our lecture is the Science of Respiratory Diseases, Interview, Inspection and Palpation of the Chest. So first of all, I want to remember you the anatomy and physiology of the chest. So our chest consists of bone structure, cartilage structure, muscles, interior chest spaces. So bone and cartilage forms protective cage, muscles assist in respiration, interior chest spaces is the site of the lower lungs. So topographic markers of the chest. We have nipples, manubriosternal junction, suprasternal notch, costal angles, vertebral prominence, and clavicules. All these are topographic markers and you need to remember them. So all these things which we talked, you see on the picture. So as you see, suprasternal notch, claviculas, second rib, body of the sternum, nipples, clavicula, manubrium, and manubriosternal junction. Also, processus xiphoidus and costal angles. So, to our main part of the lecture, and first of all, the symptoms of respiratory diseases. So, the main symptoms, we have dyspnea, cough, chest pain, and hemoptysis. As you remember from the previous lessons and lectures, we have main symptoms and additional symptoms. So main symptoms of respiratory disease, as we say, so 4 main symptoms. Elements to detail the main compliances. So please remember these elements because you can use them to any of the main compliances of the diseases. Let it be respiratory diseases or cardiovascular disease or diseases of the digestive systems, you can use it. So, number 1, localization, or you can ask where. So let it check the pain in the chest. So localization, we ask patient where you have pain. Quality, the question is how. So quality, how you feel this pain. Next one, quantity, how much. So is it severe, is it not severe? So how much pain you feel. Next one, chronology, when, how long, how often. When it appears, how long it appears in time, how often it appears. Next one, circumstances of occurrence, where and when. So it can be physical activity, walking, stress, and so on. So circumstances of occurrence. Next one, provoking factors. Provoking factors, what causes these main compliances. Relief factors, what patient do to relieve these things. So if he has pain, what he do to relieve his pain. It can be position, it can be some medicine, it can be some and other things like uh, drinking water or something else. Let it be. Next one, associated manifestations or irradiation. So patient can have pain in some, maybe in the chest, but he feels irradiation to some another parts of our body. So using these things, these elements, you can detailize any main compliances. So, and we start to talk about chest pain. So first of all, first our compliance chest pain. So what we need to know about chest pain. So first of all, remember that chest pain arises from structures in the respiratory system, including pleura, and structures not related to the respiratory system, such as chest wall. So pleuritic pain, what can cause this pain? Results from inflammation of the pleura, pleuritis. This pain is sharp, acute, is made worse by deep breathing and coughing. Usually the site of the pain can be pinpointed. Next, compliances second is dyspnea. So dyspnea or shortness of breath. What is it? It is unpleasant sensation of difficulty in the breathing. Is increasing of breathing rate and depth, results from obstructive lung disorders. The airways are narrowed, air cannot be exhaled from the lungs as fast as normal, and restrictive lung disorders. Lung becomes stiff and require increased effort to expand during inhalation. So, you know, using these things, you know that dyspnea can be two types due to exhaled or inhaled. So, two types of dyspnea, you know these things. So, next one, again about dyspnea, shortness of breath. So, what we need to ask from the patient. Onset, pattern, severity, and associated symptoms. So, next one, cough. So, cough is a familiar but complicated reflex. Is one way in which the lungs and airways are protected. Results from the airways irritation, narrowing of the airways. Coughing sometimes bring up sputum. So, as you see, cough can be dry or moisted cough. Dry cough without sputum, moisted cough with sputum. So what we need to know from the patient about coughing. So as it was in shortness of breath or dyspnea, onset, then nature of the cough, pattern, severity, associated symptoms, efforts to treat, and medications which patient used to treat his cough. So if patient compliance is about coughing, we can see this cough. So if we ask patients to cough, we describe moisture, onset, frequency, regularity, pitch loudness, and postural influences. Sputum. So if we talk about sputum, it is due to moisted cough, and if patient has sputum, we need to know color of the sputum, consistency of the sputum, and order. So due to sputum, we can find some very important things. So sputum can be sign of some specific diseases, and sputum, it is very important symptom. So hemoptysis. So if we talk about hemoptysis, it is very also important symptom. Hemoptysis, it is blood in the coughing. So coughing of the blood from the respiratory tract can often be frightening. Most causes turn out not to be serious. Results from airways irritation, narrowing of the airways. So which diseases can cause hemoptysis? It is very uh, heart diseases. So one of the main things it is cancer. Next one, tuberculosis. Uh, so one of the most hard treatable diseases. So continue to asking our patients. So first, next our step, past medical history. So we need to know if it was some thoracic traumas or surgeries, days of hospitalization for pulmonary disorders. Uh, if patient used some assisting devices to ventilate lungs. Uh, chronic pulmonary diseases, chronic disorders, and make some testing of the patient's breathing. Family history. Obligatory, we need to ask about tuberculosis, cystic fibrosis, emphysema, allergy, asthma, atopic dermatitis, and malignancy. So personal social history. So first of all, we ask about employment. So because some professions can cause chronic lung disorders. Home environment, use of tobacco, exposure to respiratory infections, flu, tuberculosis, nutritional status, regional travel exposures, hobbies, use of alcohol, drugs, and exercise tolerance. So after we ask patients, we go to inspection. So what we can find during inspection in the patient with lung disorders, lung diseases. So skin, color of the skin. It can be cyanotic skin and paler skin. So cyanotic skin due to acquiring less of oxygen. Then fingers, as you see in the picture, you see it is clubbing finger. Clubbing finger is the sign of the chronic lung diseases. Also lips and breathe. So clubbing fingers. What is clubbing fingers and how to describe this? So finger clubbing is characterized by enlarged fingertips and the loss of normal angle at the nail bed. So in the picture you see that we have normal finger, yeah, and clubbed finger. So if we put some paper or meter, centimeter, we can see that angle decrease. So this is normal angle and clubbed angle. So angle more than 180 degrees. Next one, chest. So what we need to look at the chest. So shape and symmetry of the chest wall movement, superficial venous patterns, prominence of the ribs, sternal protrusion, spinal deviation. Next one, epigastric angle. As you remember from the general inspection, we check epigastric angle to find type of chest. It can be normosthenic, hypersthenic, and hyposthenic. So if angle, we have angle in 90 degrees, it is normosthenic patient. More than 90, hypersthenic. Less than 90, hyposthenic patient. So one of the main findings in the patients with respiratory diseases during inspection, it is barrel chest. So remember, barrel chest may indicate emphysema. In the picture you see patient with barrel chest. If you look at this patient, so his chest is big and his sizes looks like barrel. So barrel chest, the sign of emphysema. Next, what can be with the chest? So pigeon chest and funnel chest. You see on the pictures. If we look at the sternum, we see these findings. So if we talk about what disease can cause, this is rahit. So diseases in the childhood. Next one, we look at the posture of the so on the spine of the patients. So we see normal. So normally we have spine. It's look like S. Yes. So it can be some changes in the spinal column, as you see in the picture. So we have two lordosis and two kyphosis normally. So also can be scoliosis. So scoliosis, it is change of the spinal column into the lateral positions. So can be kypho, it can be kyphoscoliosis, and so on. So next our step, it is dynamic inspection of the chest. In the dynamic inspection, we need to find rate of inspiration, quality of inspiration, and pattern of inspiration, and count while palpating pulse. So what we can find during dynamic inspection? So first of all, rate of the chest. You need to know that normally our rate of the chest is from 16 to 20. Less than 16 we call bradypnea. More than 20 we call tachypnea. So dyspnea, it is, as we mentioned earlier, dyspnea, it is shortness of breath. So patient has some problems in breathing. What else we can find? We can find some pathological type of breathing, so such as Kussmaul breathing, chain-Stokes breathing, Biot breathing. So no, it is, if we look at the picture, so normal breathing, we see regular and comfortable at the rate of breath. Bradypnea, slower, but they are regular. Tachypnea, fast breathing. So if we talk about pathological types of breathing. So this breath has some periods of apnea. If we look back, also we have such findings like apnea. Apnea, it is absence of breathing. So chain stocks breathing, we see different rate, periods of apnea, and different volume. Next pathological type of breathing, Kussmaul breathing. You see its indications, rapid, deep, elaborate breathing. So very fast and very big breathing. Biot breathing also characterized by periods of apnea, but if we look at the volume stays stable, except of chain stocks breathing, where volume is very different. So types of breathing. Normally, we have two types of breathing, thoracic, abdominal, and in some cases we can find paradoxic breathing. So thoracic type of breathing, more, so if we divide by on men and women, thoracic breathing more to the women, abdominal type of breathing more to the men, but it can be also like thoracic, abdominal in both men and women. Also, we have paradoxic type of breathing, so it is in diseases. Let's go ahead. So again, inspection. We continue our inspection. So inspection should focus on signs of hypoxemia. So we can find cyanotic skin, signs of respiratory difficulty. So restlessness, tachypnea, paradoxal breathing, nostril flaring, accessory muscle use. Signs of possible chronic pulmonary diseases, clubbing fingers, barrel chest, pursed lip breathing, and signs of airway obstruction, nostril flaring, stridor, wheezings, accessory muscle use, and chest retraction. So, and we go to the palpation of the chest. So what is the aim of palpation? So we need to find pulsations, tenderness, bulges, depressions, unusual movement position, elasticity of the rib cage, immovability of the sternum, and rigidity of thoracic spine. Next one. Presence of crepitation, friction rub, thoracic inspection, tactile fremitus, and position of trachea. So on the picture you see how to find position of trachea. We put our hands on the shoulders and with our big fingers we palpate trachea. So trachea, so patient has a normal position of trachea. Next step, elasticity of the chest. So to find elasticity of the chest, what we need to do? We compress chest in both anterior, posterior, and lateral direction and palpate intercostal spaces. The chest of the healthy person is elastic and yields under the pressure. In the presence of pleuritis with effusion or pleural tumor, the intercostal spaces over the affected site becomes rigid. Rigidity of the chest increases in general in the age due to affication of the costal cartilages, development of the lung emphysema, and also with filling of both pleural cavities with fluid. Next, our step, evaluating tactile or vocal parameters. So what is vocal parameters? The palpable vibration of the chest wall that result from speech. What we need to do? We ask patient to say some words while we systematically palpate the chest with the palms of our hands or with the palm of the faces of the fingers. We need to palpate chest symmetrically, so right side and left side. How we can do it? So we ask patient to turn with his back. We put both our hands, left and right, on the symmetric places and ask patient to say some words. What we will feel in the healthy patients, we feel symmetrical on the right side and on the left side, the same. So the same vibrations. On the picture you see we make palpations of the apexes of the lung, then middle position and lower borders of the lungs. In each place, our vibration that we feel should be symmetric. So what findings can be when we use palpation and tactile parameters? So normally, vibration should be equal on the both sides, left and right. So this is normal tactile parameters. Vocal parameters becomes weaker when liquid is accumulated in pleural cavity. So as you see on the left part of the picture, vibration is normal. On the right part of the picture, in the apexes we feel vibration, in the lower parts we don't feel any vibration. So weaker vocal parameters. Next one, also vocal parameters becomes weaker when gas is accumulated in the pleural cavity. So again, left part of our picture, normal tactile parameters, right part, it is weaker. Next one, vocal parameters becomes weaker in the pleural thickening. So if you look at the picture, so in this case, in the right part of the lung, it is normal. In the left part of the picture, so we hear weaker vocal parameters. So next reasons, again, vocal parameters become weakening, complete obstruction of the bronchial lumen by a tumor. So again, comparing right part normal, left part in the apex is normal, in the lower parts it's absent, so become weaker. So next thing, in which cases vocal or tactile parameters will be weaker in the both sides. So due to presence of emphysema, as you see on the picture on the both sides of the lungs, tactile parameters is weak. So patient has barrel chest, emphysema, and accumulation of the gas in the lungs. We have weaker tactile parameters. So previous pictures was about weakening of tactile parameters. Next step or next picture, we have increased tactile parameters. So first reason, the tactile parameters increased may be caused by lung consolidation. So we see right part of the picture. It is normal, left part, apex normal. In the lower borders, it is increased. So consolidation of the lungs, main reason of consolidation is pneumonia, inflammation of lung tissue. So in pneumonia, we have increased tactile parameters. Next reason, increased parameters occurs in the presence of fluids or a solid mass within the lungs. So you see in the left part, in the left lung, in the lower parts, we have fluid, solid mass. So the disease abscess of the lungs. So fluid, it will be inflammation in the lung tissue. So it causes increased parameters. So remember that fluid in the pleural cavity, tactile parameters decreases, fluid in the lung, like abscess, tactile parameters increases. Next one. Tactile parameters intensified in the presence of pulmonary tissue of an air cavity communicated with the bronchus. So cavity in the lungs, like disease like tuberculosis, also causes increasing of tactile parameters. So thank you for your attention.